Welcome to the NWA-ETC Project ECHO. I'm Kent Unruh, and I'd like to turn it over to Dr. Brian Wood, our medical director, to introduce our guest.
Well, we are honored today to welcome Dr. Ted Givens here to give a talk for us on ECHO. Dr. Givens is Section Chief of Cardiology here, has a long experience with heart disease in HIV dating back to the early era of AIDS, and I will just turn it over to Dr. Givens to start the talk.
Thanks, Brian. Good morning, good afternoon, everyone, now that it's exactly 12 o'clock. I appreciate the opportunity to be here to talk about this. My only disclaimer is that I am not an HIV doc, and I do not follow patients with HIV except to take care of their coronary disease, myocardial disease, pericardial disease, and pulmonary hypertension. So I'd like to begin just by outlining the types of topics that I want to discuss. The first is coronary disease, because as you know, it's now the most prevalent manifestation of heart disease in HIV population. And then to touch on myocardial and pericardial disease, pulmonary hypertension, and then to end up with atrial fibrillation, which we now know is an emerging increased risk in HIV disease. When I first started at the end of my cardiology fellowship was the age of the explosion in AIDS admissions to hospitals in the United States back in Boston. We saw many patients in our ICU with myocardial disease and pericardial disease. And my introduction to interest in heart failure and pericardial disease then dates to my involvement with those patients with AIDS. So I appreciate the perspective, being able to look back and say what has changed and what do we need to focus on now. It's interesting to know that currently in updated data, 15% of patients with HIV die because of cardiovascular disease. And they typically present with acute coronary syndromes rather than stable angina, although they do have documented episodes of silent ischemia, stable angina, and sudden cardiac death, which we'll come back to. The typical patient is actually a younger man, younger than average for coronary disease, mean age of 48 years, with at least 8 years of HIV disease, most commonly on ART. Almost half are smokers, which is much greater than the general population, and a good incidence of dyslipidemia. Interestingly enough, the acute coronary syndrome diagnosis is disproportionately represented in the HIV population, such that STEMI and non-STEMI occur about equally, and unstable angina a bit less common. Most of the patients with acute coronary syndromes are men, almost 100% in some series. And what we know about the treatment is that PCI, angioplasty, balloon angioplasty, stents, bypass surgery have similar efficacy in the non-HIV as in the non-HIV population. And mortality is actually similar for equivalent disease burden, all things put together. But what we also have recognized recently is that the recurrence of acute coronary syndrome is substantially higher in HIV with a hazard ratio of 6.5, and that the predictors of recurrence have to do with uncorrected dyslipidemia and the burden of HIV disease, such that untreated or less than optimally treated HIV carries a higher risk of ACS recurrence. What I found interesting looking at these data as well from Dr. Triana from Mass General is the fact that when she looked at the partners data and some other series, that the incidence of myocardial infarction is higher for every age group, even the youngest age group in 20s and 30s, and that the incidence of myocardial infarction increases with age as you'd expect, but at every age group it's higher if the individual has HIV. Risk ratio for coronary disease, the risk ratio for women is actually higher than men, although the incidence of coronary disease in women with HIV is numerically less. The risk ratio for men averages about 2 in most series, but in terms of the risk, we haven't got a complete risk profile because data on smoking is incomplete, as it is in most electronic medical records. Nonetheless, it's striking that coronary disease is so common in the HIV population at every age. So one would then wonder, how can we approach this as an independent risk factor? How do we think about reducing the risk and managing the treatment of these individuals? This is a little bit hard to see, I'm sorry to say, but what is meant to demonstrate here, as I mentioned before, is the risk for an ST segment elevation MI is actually greater statistically than non-ST segment elevation MI compared with the general population in patients with HIV. It used to be in the 1970s and 80s that ST elevation MI was twice as common as non-STEMI, but that's been reversed since about 1990 with secondary prevention. Whereas in HIV disease, that ratio still is a reflection of untreated disease in my estimation, and that the mortality rate for an MI in an HIV positive individual is going to be higher as a consequence of that, if he or she has an MI. So when we look at a comparison of risk factors with non-HIV populations here, again, the HIV populations are younger. They have similar amounts of nicotine and nicotine use, a lower incidence of premature coronary disease in some series, and a significantly lower incidence of diabetes and hypertension. But yet their metabolic disturbances are very similar to patients with diabetes and the metabolic syndrome. So our understanding of the pathophysiology of coronary disease in the ART era is really a combination of the underlying risks of the individual with HIV plus the effects of HIV and the effects of treatment for the HIV. So although many of the assessable risks for coronary disease in the HIV population still are pertinent, such as age, smoking, hypertension, atherogenic dyslipidemia, particularly low HDL and high triglycerides, what we know also is that patients with HIV who smoke have a 2.5-fold risk of coronary disease that's over and above their smoking risk if they didn't have HIV. So smoking really magnifies the risk of atherosclerosis in patients with HIV. There's lots to talk about in the subtleties here and the treatment and so forth. Dr. Subramanian, I think, gave a long, in detailed talk about this last June. Her talk is published on the website. So I'm not going to go into that except to mention that with HIV and with the dyslipidemia that occurs with that, as well as some of the other comorbidities, particularly smoking and a sedentary lifestyle, there's an enhancement of the inflammatory state, the procoagulant clotting state, and immune activation within atherosclerotic plaque, which is independent of the typical atherosclerosis, probably magnified by the presence of HIV disease. But all of these changes in the pathophysiology of the arteries are similar in non-HIV individuals, but they're magnified by both risk factors and the presence of HIV disease. It's also interesting when retrospective studies have been done that patients who interrupt ART therapy enhance both acutely and chronically the development of their coronary risk. I mention this because when you look at other traditional approaches to assessing cardiac disease or coronary disease from a metabolic standpoint, we recognize that the metabolic syndrome, with its attendant emphasis on overweight, obesity, central obesity, insulin resistance, dyslipidemia, particularly with high triglycerides and low HDL, the effect of inactivity and smoking and hypertension, all which contribute to the diagnosis of metabolic syndrome. These are the factors that are present in many of the patients with HIV who develop coronary disease. And HIV, the presence of HIV and some of the treatments of ART magnify these factors as well. So when I meet a patient who I'm referred to see with HIV disease and apparent coronary disease, I'm reminded that they are cousins to the rest of my patients with metabolic syndrome and insulin resistance, and so we focus on many of the same features. A study that I found was very interesting to look at from San Francisco, California in general, looking at stored samples of serum from patients who had had lipids available for evaluation before seroconversion to HIV positivity, and then from the time of introduction of ART therapy up to about 12 years afterwards. What we see here is that the effect on of the development of seropositivity and then treatment with ART is really just a modest decrease in HDL that is probably related to the dyslipidemia of therapy and the disease itself, and a rise of total cholesterol, which is actually proportional to age. It's no different than you'd expect from others who are aging another 12 years. So it seems that the lipid disturbance itself, although it can be dramatic in some HIV patients, is as much to do with age and other comorbidities, sedentary lifestyle, obesity, and so forth, as you would see in an aging population. All that said, we still need to focus on treating the lipids and the other risk factors that we identified. Wanted to just mention that when we used to pay attention to ATP3 in the National Cholesterol Education Guidelines, they defined the risk-equivalent conditions, that is, a risk of an MI over 10 years of at least 20%. Coronary disease, type 2 diabetes, abdominal aneurysm, symptomatic carotid disease, peripheral artery disease, or a Framingham score greater than a 20% 10-year risk. Added to that, based on most guidelines, is a coronary artery calcium score greater than the 75th percentile, and by all measures of assessable risk, chronic renal disease with a GFR less than 60. But then I was wondering, do we have enough data to say that HIV is a coronary disease risk equivalent? And I will make the argument that we don't, but that we should. So if we look at the current risk estimator, my Boston accent's coming out, risk estimator that was published by the American College of Cardiology and linked to the current 2013 guidelines for the treatment of hypercholesterolemia. So it's online. If I were to enter the average numbers for an HIV patient, a 48-year-old male with a total cholesterol of 220, an HDL of 29, and a systolic blood pressure of 142, who is not being treated for hypertension, but perhaps should, and is not diabetic, but does smoke, his 10-year risk is 16.4%, and that of that, 45% is reducible risk by modifying risk factors. So that means to me that the average baseline risk plus the HIV risk that we know is population-based is 16.4% by somewhere between 1.4 to 2, is 23 to 27%, which then means that it can be a coronary disease risk equivalent because it's greater than 20%, but it's driven by the patient's underlying risk factors that are independent of HIV, but probably magnified by HIV. So based on the current treatment guidelines, because he falls into an intermediate risk category, he should be treated, and because his HIV risk puts him above 20%, that at least means that the correctable risk factors should be treated. So how do you evaluate the CHD risk workup in a HIV positive person? Assess smoking habits and recommend stopping smoking. Look at the diet to encourage weight loss, increase exercise activity. Take a close family history for coronary disease or vascular disease, hypertension, or diabetes. Measure the baseline blood pressure, waist circumference to look for central obesity, body mass index, and get a random lipid profile just because you want to grab it and assess what the profile is. And if the fasting triglycerides are greater than 200, you're justified in having the patient come back fasting. Look for signs of undiagnosed diabetes or renal insufficiency. And if the patient has symptoms suggestive of ischemia or a markedly elevated risk based on the 2014 guidelines for coronary disease, then it's justified to do screening exercise treadmill testing. So I'm going to just briefly outline the current 2014 guidelines, which are if you have a diagnosis of stable ischemic coronary disease, you want to at least introduce aspirin and therapeutic lifestyle changes. If they cannot take aspirin, then clopidogrel is the appropriate substitute. And then focus on symptoms by being sure that you prescribe nitroglycerin, add a beta blocker for persistent symptoms. If the symptoms persist, adding a calcium channel blocker can be used for a long-acting nitrate. If this is unsuccessful, I would at that point get a cardiology consult where we would consider adding some of the newer agents such as ranolazine. But if symptoms persist, we would assume that the burden of disease is significant and they should go into a different pattern of evaluation with consideration of coronary angiography and revascularization. The reduction of risk has then again to do with stopping smoking, introduction of the appropriate statin, blood pressure control, and if they're pre-diabetic or diabetic, aiming for an improved glycemic profile. Dr. Subramanian went over this in great detail. The guidelines for the statin benefits group include established coronary disease, high LDL in adults, diabetics with a range of LDL between 70 and 190. If they're not diabetic and have more than 7.5% 10-year risk, primary prevention is appropriate, particularly in the ages of 40 to 75. I'm going to skip over this in the interest of time, but basically, many of these factors are present in our HIV population. So this is where taking a very detailed family history is going to be important, looking for inflammatory markers, which we know enhance the risk of myocardial infarction in the HIV population. Still, the prescription of a statin is a discussion between the patient and the family about long-term risk, because statins don't make you feel better, sometimes they make you feel worse, and they have to be justified. The treatment goals are to reduce LDL by at least 50% of the patient's high risk, 30 to 50% by if they're intermediate risk. And contrary to some impression, you actually remeasure the lipids to prove that you've achieved this risk reduction of 30 to 50% or greater than 50% in the, based on the assessable risk. The review by Baccara in last year's, or 2 years ago, Journal of the American College of Cardiology, and I think we understood this from Dr. Subramanian's talk, is that because of the drug interactions with the ART therapy, low-dose rosuvastatin or atorvastatin for the high-risk patients are most appropriate, and pravastatin, because of its fewer cytochrome P450 interactions, is appropriate as well. Remember that pravastatin is one of the weakest statins, so you really want to achieve a meaningful reduction rather than just expose the patient to the drug without a clinical reduction of risk. So I'm going to move on now quickly to discuss the remaining topics: left ventricular dysfunction, pericardial disease, and atrial fibrillation. It used to be, and I remember taking care of many young men with cardiomyopathies when they had AIDS. There is evidence that HIV is associated with focal myocarditis, which can be seen on biopsy or even now on cardiac MRI, whether or not the patient is undergoing ART therapy. Cardiotropic viruses have been implicated, but we know even now that symptomatic cardiomyopathy is exceedingly rare, and even in the pre-ART era was only present in in less than 5% of the population. However, in South Africa, where the combination of other infectious diseases and HIV is very high, up to 38% of new heart failure in South Africa can be related to HIV cardiomyopathy. And in the symptomatic patients, there's an inflammatory acceleration, viral contribution to the development of cardiomyopathy with these cardiotropic viruses. But in North America, we really see that many of the cardiomyopathic processes in our HIV patients who are being currently treated are alcohol, cocaine, methamphetamine, and we have to ask in detail whether these myocardial depressants are being used. We used to see that pentamidine and zidovudine were associated with left ventricular dysfunction as well. There's really no reason to think that we need to treat patients with HIV differently for left ventricular dysfunction, so we introduce the same evidence-based treatments for congestive heart failure if the patient's symptomatic, and for left ventricular dysfunction if they're asymptomatic. Rare signs now for cardiac infiltration, but when we see it, it's often related to Kaposi's sarcoma and non-Hodgkin's lymphoma. Patients with systolic dysfunction and HIV disease tend also to have autonomic dysfunction, so lightheadedness, tachycardia, prolongation of the QT, which is not just drug-related, but can be related to an autonomic dysfunction as well. So when patients have those types of symptoms or abnormal EKG, then it's worth evaluating the patient with at least careful physical exam, perhaps chest X-ray, echocardiography, and BNP level. When systolic dysfunction has been evaluated in a systematic way, it's clear that in an asymptomatic population, New York Heart Association Class 1, patients who've had a reasonably long duration of HIV disease, that 8.3% in this series had a left ventricular ejection fraction less than 55%, felt to be below normal. That's about twice what one would expect for an equivalent age group of non-HIV populations. And the predictors of systolic dysfunction are a high hsCRP, active smoking, and a history of myocardial infarction. Not too much of a surprise. The treatment, of course, is going to be the same as for non-HIV LV dysfunction. When we look at diastolic dysfunction is common in the same data set, but it really reflects the fact that there's mild diastolic dysfunction in asymptomatic individuals and severe diastolic dysfunction in others, but primarily related to age and hypertension. That's really the same pattern that we see in individuals without HIV, but the incidence is about double, just as it is for systolic dysfunction. Pericardial disease, uncommonly, although I just saw a case last week of pericardial disease in a patient with a new diagnosis of HIV. Asymptomatic pericardial effusions had been common in the pre-art area, up to 40%, very common in South Africa. And in symptomatic patients, when we see pericardial effusions, has to be assumed to be related to infection or neoplasm. In the presence of an effusion in symptomatic patients, the chances of going into pericardial tamponade are at least 30%. South Africa, the incidence of TB is closely linked to the diagnosis of HIV. And we always have to be sure that we are excluding such diagnoses as primary B-cell lymphoma and Kaposi sarcoma as well. The treatment is exactly the same. You want to tap the effusion, particularly if the patient's symptomatic. You want to drain it dry and then send for cytology and culture and treat appropriately. The presence of a pericardial effusion in a patient with HIV is a bad prognostic sign. So it actually increases the 6-month mortality by about tenfold because of the presence of the two diagnoses, usually in patients with uncontrolled HIV disease. Pulmonary hypertension, we think of this all the time when we see someone with pulmonary hypertension, but it's rare. Still, by the literature, 1 in 200 diagnosis ideally made by echo and then cath, but confounded by the fact that patients with HIV may also have Hep B or C, methamphetamine, left heart failure from coronary disease or drug abuse, intrinsic pulmonary disease, or chronic thromboembolic disease has to be considered as well in patients with pulmonary hypertension. Mixed etiologies, or the so-called type 5 pulmonary hypertension, has to be part of the workup based on clinical suspicion. The prognosis is poor, and the treatment is really the same as anyone with severe pulmonary hypertension, but it's felt that the patient should not be treated initially with calcium channel blockers and sildenafil because of lack of efficacy in this population. Let's finish up with atrial fibrillation. I mention this because it has not been emphasized except for over the last 2 years with retrospective analysis of a huge VA cohort of more than 30,000 HIV positive patients. But the bottom line is that atrial fibrillation in this large series looked at is 50% higher than the historical age group. And there are more African American affected with HIV than non-HIV infected African Americans. So this is going to be and will be a huge public health problem for the HIV population because this is an aging population with comorbidities that increase the thromboembolic risk. It is related to, it's going to be worse with a higher CD4 count and a higher viral load. And we actually don't know whether the CHA2DS2-VASc score actually estimates well our patients with HIV who have atrial fibrillation. My assumption, based on the inflammatory component of it and some of the thrombogenic profile of HIV patients, is that the CHA2DS2-VASc will probably underestimate the thromboembolic risk, but that has not been adequately studied yet. So in summary, thanks for listening, for me going a little longer than I should have, but let's just summarize by saying that the coronary risk is similar to that of the family history for premature MI, but that the comorbidities, as in family history, really dominate the risk assessment. The modifiable risk factors include smoking, dyslipidemia, obesity, hypertension, illicit drug use, excess alcohol, and a sedentary lifestyle, and to some degree ART therapy itself, although I think we're being smarter about that now, or at least you are, Dr. Jenner. The standard evidence-based medicine's approach to CAD risk reductions apply with adjustments for ART drug interactions, and that the other manifestations of heart disease, particularly myocardial, pericardial disease, venous thromboembolism, have really become less prominent but are still active diagnoses in patients with a new diagnosis of HIV or those with very low CD4 counts. And then I'd like to emphasize that atrial fibrillation is an emerging cardiovascular threat in the aging and even younger and Black population. So we need to pay attention to this and really come to some conclusion about how to adequately treat these patients, particularly if they are not capable of managing anticoagulants as an outpatient. So I'm going to stop there and thank you for your attention.